Hi everyone, my name is Nicole Tadros. I am in the nursing education department. I am here to talk to you today about acute coronary syndrome. A little bit about me. My background is all in cardiac care. I worked in the CV-ICU, and after that I moved on to the cardiac cath lab where I worked with patients that needed minimally invasive cardiac procedures. So my entire background is in cardiac patients. Today I'm going to talk to you about acute coronary syndrome and chest pain and what to do if your patient starts having chest pain. UHS Wilson Hospital is an accredited chest pain center, which means we perform PCI and primary resuscitation. So we have a cardiac cath lab here intervening in people's coronary arteries, meaning that we can fix someone that's having a heart attack, attempt to intervene, put in a stent. The cath lab team is on call 24/7, 365 days a year. There is never a time when the cath lab cannot be called in to perform these procedures. So my objectives for this presentation is to teach you what you should know about chest pain and what to do if your patient has chest pain, what to do if your patient has a cardiac emergency. I know not everyone here works on a cardiac unit, a telemetry unit. You don't all work in critical care. You all work in a variety of areas, but I want you all to know that even on main tower 5 in the corner room, you could have a patient that has chest pain and you might want to know this information. So try to keep it in the back of your mind for a future incident. So let's talk about chest pain. Not all chest pain is cardiac in nature, but we are going to talk, the majority of this is going to be talking about chest pain that is due to acute coronary syndrome. So other non-cardiac causes of chest pain can include a dissecting aortic aneurysm, a pulmonary embolus, a pneumothorax, esophageal rupture, an acute exacerbation of heart failure can cause chest pain as well. You can have reflux that's causing chest pain from GERD or something. Any trauma, chest trauma or something can absolutely cause chest pain. And then lupus, panic attacks, and anxiety can also cause chest pain as well. So talking about coronary causes of chest pain, typically when we're looking at cardiac and acute coronary syndromes, we're going to talk about, we will just gloss over stable angina, but we're going to talk about unstable angina, NSTEMIs, and STEMIs. So angina is a medical word for chest pain. So if your patient's having chest pain, angina is typically cardiac in nature. So stable angina, we're not going to worry about today. Patients with unstable angina fall on one side of the acute coronary syndrome umbrella, and then we have an NSTEMI, which is a non-ST elevated myocardial infarction, and we'll get to what that means in a few minutes. And then we have STEMIs, an ST elevated myocardial infarction, and this on the other side is the high risk. This is the big guy, the bad heart attack, the kind you might see on TV where a person's clutching their chest and bending over and they're in excruciating pain and etc. That is a very Hollywood example of a quote-unquote STEMI. So when we're looking at acute coronary syndrome, say you have a patient, a workup for acute coronary syndrome in its most basic form is going to include talking about patient's symptoms, chest pain, shortness of breath, all of these things that can go along with this. And then you're also going to be looking at their EKG. You're going to have a 12-lead EKG on these patients available. And then you're also going to look at cardiac enzymes. So those cardiac enzymes are the CKMB, the troponin, those, little green top tube that the lab's going to come and draw and it's going to result and come back. We want those cardiac enzymes to be negative. At baseline, everybody should have negative cardiac enzymes. My troponin hopefully should be 0. My CKMB should be 0. Everything should be normal and good to go. When those cardiac enzymes begin trending upward, that means there's damage to the cardiac muscle, that myocardium. So let's look at unstable angina. So this is a branch of acute coronary syndrome that can come with chest pain, possible EKG changes such as ST depression and T-wave inversion, and stable troponin, stable cardiac biomarkers. Those cardiac enzymes remain negative and at 0. When we start working our way up to an NSTEMI, that non-ST elevated myocardial infarction, this is a branch of acute coronary syndrome that includes chest pain, potentially, possible EKG changes such as ST depression and T-wave inversions, and elevated cardiac biomarkers. So we're looking at those cardiac enzymes start trending up. We have a positive troponin come back. We have the CKMB starts to rise, etc. So that's in the NSTEMI category. We have to have positive cardiac biomarkers to be considered an NSTEMI, but negative EKG for ST elevation. So unstable angina and NSTEMI patients are not immediately life-threatening typically, but they need to be evaluated quickly and treated accordingly. The disease process is due to impaired myocardial perfusion due to a partially obstructed blood flow through the coronary arteries. And that partially obstructed, we'll see in a future slide, but that is really the key difference between NSTEMI, unstable angina. They are partially obstructed blood flow versus a STEMI, as we'll see soon, is completely obstructed blood flow. So with a STEMI, an ST elevated myocardial infarction, that EKG now has ST elevation. So if you're looking at that PQRST, that full length of one beat of the heart, that ST segment is elevated from the baseline. So we have an ST elevated myocardial infarction. So myocardial infarction means the myocardium, that heart muscle, is not getting enough blood flow. So STEMIs are due to completely obstructed blood flow through the coronary arteries. And those STEMIs are characterized by chest pain, definitive ST elevation on the EKG with possible reciprocal changes, with some ST depression, maybe T-wave inversions in other leads. There can be a lot going on in a STEMI EKG, but the ST elevation is key. And then STEMIs also typically come with elevated cardiac enzymes. So the troponin will probably be positive, CKMB will be positive, etc. The big thing about cardiac enzymes with a STEMI is if a person has an EKG that says STEMI, we are not waiting for the cardiac enzymes to show up as positive. We might not even wait for them to be drawn before that person's on their way to the cath lab. So here on this slide, as I mentioned previously, you can see partially obstructed blood flow on the upper portion of the slide. So if you look at the top left of your screen, you will see a right coronary artery, and that's the one that looks like a big C. That right coronary artery looks like it has some pinches in it or like somebody took a bite out of it. That is partially obstructed blood flow going through a right coronary artery. Versus in the top middle of the screen, you see that completely unobstructed blood flow, that nice C, you can see the dye flowing through the artery beautifully. That is what we want a typical coronary artery to look like versus the one in the top left. That is either some sort of acute coronary syndrome disease process or an NSTEMI potentially. Versus if we're looking at the bottom of the screen, the bottom middle, it's actually labeled A. That is a completely blocked coronary artery, quite proximal up in the artery. So this is most likely this patient is presenting as a STEMI. So you'll see that that blood flow is completely blocked. There is no blood flow going through to the rest of the artery, and that part of the heart is suffering. And if you see B, this is an after picture. You can see that that blood flow is restored with a stent or balloon or whatever they did, and that blood flow is now restored. STEMI is gone, and luckily this patient is fixed. All right, this is our acute coronary syndrome algorithm. So our ACS algorithm is what we will be working through for chest pain patients, whether you are in the ER and a patient walks in with chest pain, or if you're in some inpatient unit and your patient starts having chest pain. So for onset of chest pain or associated symptoms that can be linked to acute coronary syndrome, we're going to start working through this, whether we're aware of it or not. You're going to go in, assess your patient, get some vital signs, assess their mental status and everything. From the time of onset of chest pain or associated symptoms to when a provider needs to read an EKG, it has to be 10 minutes. So the patient starts having chest pain or similar symptoms. You're going to call the provider. If you can't get a hold of the provider, call a rapid response, or if your patient's decompensating, call a rapid response. If you need extra hands, call a rapid response. I'm going to keep saying that. So you'll call, you'll get a stat EKG. EKG or cardiopulmonary or respiratory therapy, depending on what hours you work and what time of day and week it is, will come. They will perform the EKG. That EKG that was just printed needs to be read by a provider within 10 minutes of the onset of chest pain. So you're getting a stat EKG is done, provider is present at the bedside reading the EKG. If that says STEMI, then we're going to start working through the rest of this algorithm. We're going to start doing some other things. So let's say you get the new EKG and this is what it looks like. Well, this is ST elevation and this is not good. So this patient's having a STEMI. If the patient is having a STEMI or if the provider suspects it's a STEMI based on the EKG or other symptoms, we're going to give the interventional cardiologist a call. The interventional cardiologist, there's always an interventional cardiologist on call, just like the cath lab, 24/7, 365. We are going to call this provider and not the regular on-call cardiologist. The regular on-call cardiologist is not necessarily a credentialed that has a fellowship in interventional cardiology, etc. So they might not be able to perform the procedure that we need to do to fix this heart, to take care of this STEMI and this intervention. So we're going to call the interventional cardiologist. If you don't know who the interventional cardiologist is, the ER always knows. You can always give them a quick call and ask. To decrease the traffic calling to the ER, you can also look at the on-call finder, or you could call the cardiology office. They have on-call staff that will tell you so-and-so is the provider, or they can send out a page to so-and-so and let them know that there is a STEMI on such and such unit. All right, once we get that EKG and a provider reads it, we're calling the interventional cardiologist. The only providers that should be calling in the cath lab are the interventional cardiologist that is on call or the emergency room doctor. If you're in the emergency room and the patient comes in and they determine it's a STEMI there, the emergency room doctor can absolutely call in the cath lab as well. So they will call a STEMI, cath lab will come in to care for your patient. If it is an inpatient STEMI, the patient's going to go to the cath lab within the hour. Door to balloon time is from onset of chest pain to when an inpatient should be getting fixed in the cath lab is 45 minutes, so expect them to be whisked away well within that hour. If you call a STEMI code on an inpatient unit and on an inpatient person, you will get a SWAT nurse that comes to the bedside if they're not already there from a rapid response or something, and they will bring the STEMI box. All right, so your patient has a STEMI. They called in the cath lab, everything's happening, SWAT's there. Let's talk about what you're responsible for as the primary nurse of this patient. So this patient needs to be prepped, meaning they need to be shaved, preferably their right groin, a 4x4 centimeter box around their femoral artery. That is most likely access point they're going to need to fix this person's heart. You're going to be getting some medication orders for this patient, whether it's from, the rapid response team or the interventional cardiologist is calling them to a physician or to you, or they're putting it in the computer. And these medications you may anticipate is IV heparin, aspirin, and a P2Y12. So a P2Y12 is a platelet aggregate. These medications, you may know them by the names Brilinta, Plavix, or Effient. These medications work with aspirin in particular, but they also work by themselves to prevent platelets from sticking together and clogging up arteries. So we use these on patients that have stents or are getting stents or have a high likelihood of platelets sticking to their clots that they have, if they have known clots or blockages. So we will give this patient a P2Y12 inhibitor, Plavix, Brilinta, Effient, whatever, and this, when they get their stent, when they're taken to the cath lab to get a stent into their coronary artery, this will prevent the platelets from sticking to it. If your patient's not already on a P2Y12 inhibitor, like if you've never seen Effient, Plavix, or Brilinta on their med chart or anything, anticipate that they will get loaded with these. So they will not just get one dose, they'll get a large loading dose. And for Plavix, that looks like 8 pills, or for Brilinta, that could be 2 pills. It's different for each medication. So in addition to that, you need to make sure that the family's updated, and it's not necessarily your responsibility. You're in there caring for the patient, doing all the things, giving all the meds. So one of the providers, whether it's a resident that came to the rapid response or your charge nurse, somebody needs to be calling the family and saying, hey, there's an acute change in condition and this patient's going to the cath lab. If you're not already in the CVICU, all of my non-CVICU nurses that are listening right now, this patient's not going to come back to you. This patient's going to go to the CVICU after they have their procedure. They're going to go get their artery fixed, and then they're going to go to the CVICU. All STEMIs get their post-care in the CVICU for a minimum of 24 hours, and then maybe they can go to a tele-unit, a cardiac tele-unit. Other do's and don'ts of cath lab prep. So you're going to do all those things. Something I don't want you to do, I don't want you to take the time to get consents. I know that sounds kind of funny in a world where we want to, document everything and make sure everything's, we have permissions for this and that. And I totally understand that. But as a former cath lab nurse, when we take a patient down for a STEMI, an emergent procedure, number one, it's an emergency procedure, so I'm not going to take the time to get the papers and sign them, make sure the doctor signs them here and there, and make sure they're all correct and everything. While I'm rolling this patient down in the elevator, I'm going to look at them and say, this is what we're doing. This is what's happening. Are you okay with this? What questions do you have? Because the doctor and I are both going to be there rolling them into the cath lab and talking to them about this at length during that time. It's not a stop and sign paperwork kind of scenario. This is an emergency. STEMIs are very emergent, so we need to get moving, and taking the time to sign that paperwork does not help that. There are some other things you can anticipate when you have a STEMI patient or any chest pain patient. We're going to talk about MONA. Does anyone remember MONA from nursing school? Well, MONA looks a little different now. There's a silent F there. So we're going to talk about what MONA is and what we do for these patients. So for cardiac patients, patients with cardiac chest pain, acute coronary syndrome, STEMIs, NSTEMIs, unstable angina maybe, we're going to be working through this MONA algorithm here. Morphine, the M and F kind of go together. So we're going to give this patient potentially morphine or fentanyl for that chest pain. So the morphine decreases myocardial oxygen demand, and it helps with pain management, so it really helps with that cardiac chest pain. However, morphine also interferes with those P2Y12s, those platelet aggregate medications, so we don't necessarily want to give morphine as the first line anymore. So we're working a little bit more towards fentanyl. They can get a small dose of fentanyl typically. We give fentanyl in the cath lab for the conscious sedation, so they're going to be getting some of that regardless. So unless there is some sort of contraindication, allergy or something, fentanyl is probably going to be our first line pain medication we'll see ordered for this patient. We're also going to potentially give this patient oxygen. So we're not hyperoxygenating them necessarily. If their SATs are okay and they're not short of breath, we don't necessarily need to put oxygen on these patients. We want to keep their SATs at a stable rate, it's at 92 and above, let's say, but we don't need to hyperoxygenate them. So oxygen's maybe we'll do that. It's always good to have in our back pocket, absolutely. Nitro. So nitroglycerin, we're probably going to give maybe a sublingual nitro dose. That sublingual nitro is a vasodilator. Not only is it good for chest pain, but it also helps dilate those coronary arteries. There are a couple of contraindications for nitro though, so if you are very familiar with this patient and they take, let's say they take tadalafil, Cialis, or if they take Viagra at home, they've had it recently, they take it regularly, that's a contraindication. We should not mix sublingual nitro or any nitro with those medications. The combination can dangerously drop their blood pressure to very low or deadly levels. And with a patient that's having a heart attack, we certainly don't want to make things any worse for them. So if you know your patient, let's say you have a patient that has pulmonary hypertension, they're on Cialis at home for that, not necessarily for erectile dysfunction, for anything that Cialis or Viagra are used for, you're not going to say, hey, yeah, let's give you some sublingual nitro for a patient like that, that can cause serious issues. It makes them more sensitive to nitro, and it can certainly drop their blood pressure. Another patient you don't want to just, feed sublingual nitro to like it's candy, which we do for some chest pain patients, but another one that you don't want to do that for is a patient that has an inferior myocardial infarction. So if you're looking at the EKG and you're like, it says STEMI, inferior, I would pause and say, hey, I think there's something about nitro we're not supposed to do. There's a lot of pathophysiology I could go into here. If you want to hear me talk about it forever, I can certainly do that. You can shoot me an email or give me a call. But right now, I'm just going to tell you that inferior myocardial infarctions that it may say at the top of your EKG, or it may be determined that your patient has, they already have low blood pressure to begin with, typically. They also can be bradycardic. Giving them nitroglycerin can also dangerously drop their blood pressure in this scenario, and we do not want that to happen for these patients, of course. And the A in MONA is aspirin. So we're going to be giving all of these patients aspirin typically, unless contraindicated. Aspirin is a light antiplatelet medication. Typically load them with 324 for baby aspirins, chewable. But if they take it at home, they were given to it by EMS or in the ED, or they've been getting it every day on the unit, we don't necessarily have to do that. One thing I do want to mention, it's not part of the MONA family, but TNK. So TNK is a clot busting medication. If your patient is determined to have a STEMI and they, for whatever reason, cannot go to the cath lab, whether it's your patient, they called 3 other STEMIs and your patient was the most recent one and there's just no way they could get to the cath lab in a timely fashion, or something's contraindicated for your patient and they are severely allergic to something, or whatever. Let's say they are more appropriate for TNK. They may get this 1 dose of clot busting medication to break up the clot, as opposed to getting a stent. I've seen it before. It works pretty well, but it also has a lot of side effects. Obviously, with this clot busting medication, it doesn't just bust the clot that's in the coronary arteries, potentially occluding it. It can bust all of the clots. So your patient is a huge bleeding risk. These patients need to be monitored in critical care for a minimum of 24 hours after we give them TNK, with bleeding precautions and all kinds of other things, frequent neurochecks. It's very elaborate and very scary for these patients. So keep that in mind if you do have a patient that gets TNK. All right, so we've talked about STEMIs, but we also talked about NSTEMIs and acute coronary syndrome. So what if your patient, you have a patient that has chest pain, you get that stat EKG, and all the providers and everyone's looking at it, and you see it says it's not a STEMI, or it says, normal sinus rhythm, or whatever. So what do? There's a lot of other things it could be, and let's talk about them. So we're going to talk about NSTEMIs. NSTEMIs can be they're not emergent, but they can be quite urgent. They can be stable or unstable. NSTEMI patients can, certainly present in a variety of different ways, depending on the blockage and how severe and their history and all kinds of things. So your EKG may look like this. There may be ST depression. There may be a T wave inversion. There may be all kinds of other funky things going on. So the only way to really determine how severe an NSTEMI is you're going to trend those cardiac biomarkers, those cardiac enzymes, but the gold standard is taking this patient to the cath lab and actually physically looking at their coronary arteries. So this patient is going to go to the cath lab. It might not be at 2 in the morning when you called the rapid and had the patient come and everyone, all the things were happening, but this patient will go to the cath lab and they will potentially get an intervention very soon. So prior to going to the cath lab for that coronary angiogram, they may have a stress test. They may have a CT of their coronary arteries. They may get some medical management. So we're going to talk about that as well. Medical management for an NSTEMI or acute coronary syndrome patient could look different for every single patient, but let's talk about some things that are generally common themes. These are the patients that you're going to see on a heparin drip for ACS protocol. There's different heparin drips and different protocols for each one, but this acute coronary syndrome heparin drip, this is an appropriate use for that. Other medications you're going to be giving this patient is potentially sublingual nitro. Everybody loves sublingual nitro for chest pain patients, and this may be an appropriate choice for them. These patients are also going to be on ACE inhibitors or ARBs. And ACE inhibitors and ARBs, they not only do they decrease blood pressure, but they also increase the effectiveness in how the heart pumps, as well as beta blockers. Beta blockers slow down the heart rate and increase the amount of cardiac output that your heart is trying to beat out. So it's really trying to take that workload off of the heart and increase the amount of actual output it has. Your patients are probably also going to be on statins. A lot of cardiologists put a lot of patients on statins, but anyone with acute coronary syndrome should absolutely be on some sort of statin or something to help with the cholesterol. And the statins just help stabilize the cholesterol that's in the patient's system. Doesn't necessarily like lower their cholesterol immediately, anything like that. But most acute coronary syndrome patients will be on statins, particularly high doses, the more severe they are. And then these patients may also be on those long-acting nitrates. So you have the sublingual nitroglycerin, that is a short-acting nitrate. You can give it, every 5 minutes, up to 3 doses, etc. But long-acting nitrates like Imdur or isosorbide, it's also called, you may have these patients on those to kind of give a prolonged relief from that chest pain. All right, everyone, you made it. Thank you for listening to my PowerPoint on acute coronary syndrome and chest pain. I hope you all learned a little something today. If you have any questions or if you would like me to talk at you a little bit more about any of these things, please let me know. My email and my office phone number are on the slide, and I will see you in residency. Have a good one.